My project is education and the effects on rehospitalization in home care patients with heart failure. It is actually a quantitative study, and the reason I picked this topic, I worked in home care for about 10 years and saw a real need for education with heart failure patients. The rehospitalization rate right now for heart failure patients is about 33% in the nation. So actually it's 27%. Where I worked, it was 33%. So we knew that we had a big gap there. Patients, you know, within 30 days going back to the hospital. So I had a real passion for this. I do not work in home care anymore, but I do hope to go back to home care someday and actually do this study. So right now I'm actually working in information technology, as you would not believe. But anyway, I tried to do something different. But anyway, I do hope to go back to home care to do this study. A little background about heart failure. About 550,000 cases of heart failure are diagnosed each year. So we know that it's a very, very big problem. And just like any chronic disease, you know, just like diabetes, we have to have a way to manage this cost-wise and for the patients. Due to new interventions, people are living a lot longer with heart failure. It used to be basically a death sentence. Now people are living 20, 30 years with this disease. So we've got to find a way to manage this. Now this literature actually is a little old because I was just looking the other day. This says within 90 days of discharge, 1/3 are readmitted back to the hospital. Now they're saying it's within 30 days, 1/3 are getting readmitted. So the trend is kind of sloping. So I thought to myself, there's got to be some benefits to education in the home care setting for these type of patients. So I thought, what can I do with that? As I was looking through the literature, I didn't find much about I found a lot of specific things to manage heart failure, but not as a group of like really what are the best interventions to do. So these are the actual goals that we would want all of our patients to get to. We would want them to be able to monitor their weight, understand their diet, and not just tell them you're on a low sodium diet. Okay, what does that mean? I don't know what that means. So understanding their medications, and if they're not on the right medications, let's get them on the right medications. Understanding their signs and symptoms of exacerbation. A lot of patients don't know, so they're running back to the ER when they could have called their doctor 3 days earlier and you know, done something about it. Now they're being admitted. And they really need to understand their disease process. I don't know how many times I went to a patient's home and they're like, what really is heart failure? Or am I going to die tomorrow? They really didn't understand it. So these are the goals that we would want them to have, to be able to reach. This is my problem statement. Heart failure patients may lack the education to manage their disease, such as their diet, their medication management, their signs and symptoms of exacerbation after they are discharged from the hospital. And a lot of times the lack of education often results in readmissions to the hospital. Where I worked, the hospital actually gave them a piece of paper that said, here's your discharge instructions. The patient went home and they're looking at them going, I don't know what they're talking about. What am I supposed to do with this? So needless to say, they went on with their normal lives and back they were to the hospital. So I thought home care would be an excellent place to intervene with this. The purpose of the study is to examine the efficacy of education done by registered nurses in the home care setting about heart failure disease management to prevent these rehospitalizations of the heart failure patients. I really wanted to see if there was a correlation between education done in the home and the rate of rehospitalization. My population are going to be heart failure patients in the home care setting, age 65 and over. And the reason I picked 65, that's when patients are eligible for their Medicare benefit for home care. So I picked that age group to start with. My intervention will be the heart bundle education, which I'll talk about in a few minutes. So that education will be bundled together. And the comparison will just be patients not getting any heart failure education. And hopefully our outcome will be there is a decrease in rehospitalization of these heart failure patients in this particular setting. Okay, my research question. Does education about heart failure disease management done by registered nurses decrease rehospitalizations in home care patients with heart failure? And my independent variable here would be my education about the heart failure and my dependent variable would be the decrease in rehospitalizations with patients with heart failure. When I was looking at theorists, and I know Dawn was talking about most schools don't teach on one theory. I went to, I did my bachelor's program online at the University of Phoenix, and our whole program was based on Orum's theory. So, I mean, we did a little bit with others, but we used Orum a lot. And Orum really uses the nurse in her theory, and she bases it on that the patient has a self-care deficit that needs nursing care. And it can be on many different levels. It can be on wholly compensatory care, which means you're giving total care to the patient as an acute care setting, or partially compensatory care, which patient's doing some care, you're doing others, or the supportive educative role, which I chose for my theory because or my study because you're actually working with the patient and supporting them in the home care setting. And what Orum says is that the patient has a self-care deficit. In this case, it would be the knowledge to manage their disease. And also, she says, self-care agency is actually the ability to perform their self-care. So, do they have self-care agency? Are they able to do what they need to perform their self-care? Because the goal is we want them to be able to manage this on their own, because we're not going to be there for them 24/7. So, every person has a health deviation, which creates this self-care deficit. So in this case, our health deviation is the heart failure, which is creating the self-care deficit. So in the end, the RN and the patient set mutual goals together and move forward to try to get to wellness. Also, tied Orum's model in with the nursing process, we have the assessment, planning, implementation, and evaluation. The assessment phase is assessing, do they have a knowledge deficit? What don't they know about heart failure? And then we can go from there. The planning phase is actually sitting down, setting the goals with the patient. This is what we need to meet. This is a criteria that you would have to meet to maintain wellness. And at this point, the nurse is supporting and educating. The implementation phase is actually giving the actual heart failure bundle education. So the nurse would actually be doing her intervention here. In the evaluation, we hope that patients are not readmitted to the hospital. We would hope after this. Okay, literature review. I combed articles and combed articles. There is a ton of literature back in the 90s, a ton of literature from the 90s and early 2000s. And then the literature kind of phased off on heart failure and disease management programs in general. And then now that I'm looking again, it's starting to resurge, and I'm pretty sure it's because of everybody's going to be getting paid for their outcomes. So now everybody's jumping on the bandwagon. We got to do something. We got to do something. So a lot of this literature is from the early 2000s that I found. The first study was Armola. Armola, they actually did a study with patients. They looked at their functional class of heart failure, if they had any follow-up plans with their doctors or whatever, and they looked at 187 charts. And what they found were patients readmitted to the hospital within 30 days had a higher heart failure class and no specific follow-up plan or education. So basically, they were discharged home and pretty much not followed up with. Krumholtz was another earlier study. Krumholtz actually examined the effects of a targeted education support on rate of readmissions, and this was an actual randomized controlled study. They had 44 people in the control group, 44 in the intervention group, and they had a nurse go out within the first week after discharge, give 1 hour of education, and then they actually did follow-up telephone calls reinforcing the education for up to 1 year. And what they found was including patient and care and providing support and education has a good outcome towards survival, and the cost was a lot less also. 25 patients in the readmission or in the intervention group ended up going back to the hospital within a year, and 36 patients in the control group. ACOSH did a study in 2002, and this one was another heart failure program in the home. 3-month enrollment for these patients, and there was 2 groups, one that received usual care from their provider and one that saw a nurse practitioner and a nurse educator in the home. And they were educated, and they also had a physical exam by the nurse practitioner while they were out there. And they found that frequent evaluations, early outpatient visits after discharge, and education focused on their self-care led to better outcomes. They actually taught them how to continue on after they were gone, after the healthcare people were gone. Lehman did another interesting study on telehealth, which is a very important part of this. And it was a small study. It was done in a New York City hospital, and there was 10 people in each group, control group and the telehealth group. And what they found was telehealth decreased utilization of healthcare by 41%, ED visits by 33%, and hospital readmissions by 29%. So that was a really good study, driving home the need for telehealth and for following up. Once the people are off the telehealth monitor, you still teach them. They can check their blood pressure, their pulse, check their ankles for fluid. So it really gets them in that mode to continue. And we have the Zalkowski, 2009. This is one of the newer studies that we found. This study actually looked at 10 randomized control trials that had been done on previous studies, and it looked at if there's more people involved, is there better outcomes? So, and what they did find is that the more people were involved, either social workers, physical therapists, nurse practitioners, nurse educators, the lower rate of rehospitalizations when you had more people involved. So, and in home care we do have a lot of people involved, so I thought that really was good for this study. The last one is Inglis. This was the first study that actually did a long-term study. This was a 10-year study. And they looked at 297 patients. Half were in the control group, half were in the intervention group. And they also got education after they were discharged in the home. Not specific on what the education was, though, so I'm not sure what they actually taught on. But the survival rate for those in the home-based intervention group doubled compared to those in the control group. So another point to say that follow-up is very important. Summary of the evidence. Pretty much all the evidence that I looked at stated, basically heart failure education does help prevent rehospitalizations. It really does impact it. There's very little literature about the heart failure bundle, which I'm going to show you in a minute as my intervention. It's actually, a lot of studies just looked at monitoring weight, or a lot of studies just looking at the diet. But doing all the interventions together at every visit, every time with the patient, really, I would hope, is going to drive this home to the patient. So this is really the first time that I've seen bringing it all together. So there's not a lot in the literature about bringing it all together. And another thing about the studies, follow-up with the patients is crucial to the outcomes. It really is. The ones that are just sent home with that piece of paper, study after study showed that they're coming back. So we really need to do something there. Application to nursing practice. Using best practices, the bundle that myself and our cohorts kind of put together at the home care agency was all based on best practices, and we know we have to continue to move to that way. And the thing is, though, every time I read the literature, there's something new, so you have to make sure you keep up on this stuff and make sure you're educating on the latest and greatest. So, but that's kind of the fun of it, is you're always looking for the new and what can we do better. So, and we always want to improve our outcomes for our patient and our organization, because we are moving towards a Medicare pay-per-performance, and I know a lot of hospitals are not going to get paid if they have heart failure patients coming back within 30 days. So we've got to really, really look at this. And of course, as nurses, we want better quality of life for our patients. We don't like to see them keep coming back in, and we have to figure out a way to handle these chronic diseases, especially heart failure. My research design, I decided to do a descriptive correlation study with a retrospective chart review. I wanted to examine the relationship between education done by the RNs and rate of rehospitalization. This study, I'm not trying to do a cause and effect relationship, because I think it would be quite hard because there's so many variables. And I mentioned that in my last slide here about behavior with patients, and we see it in home care that no matter how much you teach them, some of them just choose not to do what you need them to do. So, you know, there's not much you can do. You can't break their legs and say you have to do this. So, so hopefully, though, this knowledge that I hope to do this study someday could be used to go on and do further research in this topic. This is the actual heart failure bundle. These are the actual evidence-based interventions we would use with the patient. So this is the actual education they would get. How to check their weights and when to call the doctor. Actual real education on low sodium diet, and if this means going through their cupboards to find what they have, this means going through their cupboards and doing that. If we need to get a nutritionist involved, we will. Educate on med management, make sure they're on the latest evidence-based medications, and if they're not, getting with the doctor and asking, is there a contraindication, or is there some reason they can't be on these medications? Of course, we want to educate on their signs and symptoms of fluid retention, making sure once they're left the home care agency that they are going to be able to manage this. And educating on their disease process and when to call the doctor. And telehealth is a big part of this. And people in the study will be on telehealth as long as they are with us, so they have to consent to be on the telehealth and then actually learn how to, and it could be their caregiver learning how to take blood pressures and their pulse and looking at their ankles daily and looking at their weights. My sample will be heart failure patients, male and female over 65, admitted to home care. I'm going to approximately, if I ever do the study, hopefully I can get about 200 patients, I don't know. They would be released from the hospital with an ICD-9 code of 428.0 to 428.9. Those are the heart failure codes, and we get those when we get the referral to the home care agency. And these are going to be new patients to us. They're not going to be ones maybe that went into the hospital and then all of a sudden come back to us. They're going to be new within the last 60 days. They can't have had an episode within the last 60 days. And the patients will be excluded if they're hospice appropriate, terminal patients, or if they do not want the telehealth, because telehealth really is a part of the monitoring and education process. I'm going to use the OASIS as my data collection, which is the Outcome and Assessment Information Set. It's a standardized tool they use in home care. They collect data at admission, transfer, research, certification every 60 days, and discharge. And there's two questions I'm going to look at. The first question is reason for emergent care. For what reason did the patient receive emergent care? And they're going to pick number 5. I couldn't fit them all on the slide. There's like 20 diseases, but heart failure is the one we're going to be looking for. Did they go back to the hospital for heart failure? And then the second question is if the patient has been diagnosed with heart failure and has exhibited symptoms indicative of heart failure since the previous OASIS assessment, which would probably be the admission because we would be doing this on transfer or discharge, what actions have been taken to respond? And we're going to be looking at that. They're going to answer number 4, patient education or other clinical interventions obtained. Because once the nurses are educated on this, they are going to know that the heart failure patients, by looking in the chart, should have gotten this patient education, every heart failure patient that was admitted, and they're going to know which ones are in the study. So we're going to look to see if there's a correlation. So the study's going to run for 6 months. Data collection could take longer because I want to look at each patient for 6 months, but so if they're admitted towards the end of the 6 months, they're still going to have their time in home care, which could only be a couple months. It could be 6 months, but they're not going to go beyond 6 months. And then I want to put those 2 questions into a database such as SPSS to see if there's a correlation. And hopefully with that education, hopefully I'm seeing that education was given, yes, and rehospitalization, no rehospitalizations, I'm hoping. I'm hoping that I'm not seeing any data there, but there could be. So in conclusion, these are my references. I think a lot more needs to be done with this, and I'm hoping to carry this study out someday, if I get back to the home care arena. And then hopefully I can do a more controlled study with it after. Thank you.